Thank you very much for joining this session. So welcome to London, albeit virtually for most of you. This is one of the early sessions of the London Global Cancer Week. This is the AORTIC session. AORTIC standing for the African Organization for Research and Training in Cancer. My name is Professor Francis Chinagwundo. By day, I'm a consultant urological surgeon based in London in the UK. One of my other responsibilities is the AORTIC Vice President for Europe. And because this is a London Global Cancer Week, I was tasked with arranging the AORTIC session this year. So I'm grateful to the AORTIC Secretariat, mainly the CEO, Belmira Rodriguez, and the Office Manager, Sky Wilson, for helping with the logistics of putting this Zoom meeting together. What we thought we'd do this year was have the theme of advocacy, whether for adult or pediatric services. So we have an excellent lineup of speakers for you this afternoon. The program is little different from that which was previously advertised, because unfortunately, due to bereavements, two of our speakers, namely Chite and Udi, are unable to speak. We've managed to bring in Professor Alan Davidson from South Africa, who's kindly stepped into the breach, for which we are grateful. So my role is the moderator, and I will also introduce the speakers. I wasn't actually planning to say much apart from that, but as there's a small gap in the agenda, I thought I'd introduce the subject of advocacy, so we all know what it is that we're talking about. So what I'm going to say really is taken from an article that one of our members, Kwanele, published some years ago. Kwanele is a well-known cancer advocate in South Africa, and has been on various government task force in terms of raising the cancer agenda. So she published an article some years ago, giving her views on advocacy and how we could learn from what happened with the HIV advocacy in South Africa. So my opening remarks are really taken from her paper. So the burden of cancer is climbing in all of Africa, and yet the continent's healthcare and political systems have not as yet prioritized cancer control and cancer treatment. And Sub-Saharan Africa is predicted to have a greater than 85% increase in the burden of cancer by 2030. However, many African communities have little or no knowledge about cancer. As a result, patients present with advanced disease at the first consultation, which not surprisingly leads to poor outcomes. We need a focused approach to address this growing public health threat. Robust engagement by patients and persons affected by cancer is needed to exert pressure on key public health influencers, especially clinicians, researchers, political leaders, and public health policymakers, in order to prioritize the disease and to ease the massive human suffering caused by cancer morbidities and mortalities. Now, involving well-trained patient advocates in setting the research and overall cancer control agendas has proven beneficial in countries such as the US and the UK in improving the quality of care for cancer sufferers and their families. In addition, the involvement of patient advocates ensures that financial and other resources are spent where they are mostly needed, rather than on studies or programs that are of academic interest, but of little direct value to actual patients. It is imperative that research funds are spent on studies which will lead to the development of preventative vaccines and treatments to eradicate cancer. Patient advocacy is an area of lay specialization in healthcare concerned with patient education about health rights and how to obtain needed cancer treatment and control. Patient advocates provide the healthcare knowledge to the public at large and mainly offer the services on a non-for-profit basis. More broadly, patient advocacy can include groups that develop policies and legislation to improve systems or processes for patients. Patient advocates can also be non-patients from disciplines like social work or health insurance, employed to assist patients unravel health plans and to chaperone them through a healthcare system. It is worth noting that working within the non-for-profit sector as a patient advocate can create a conflict of interest, as it can be difficult for an advocate to protect patients' interests within the sector in which they are employed. In the US, non-for-profit organizations are recognized as key healthcare partners. However, patient advocacy is still in its relative infancy in most African countries, especially in the area of cancer advocacy. African healthcare practitioners and policymakers still, on the whole, tend to practice paternalistic medicine with little meaningful patient engagement or participation in treatment decision-making. Low literacy levels, lack of easy access to the internet, patriarchy and gender inequity in most African communities are responsible for the continuation of these unequal relationships between physicians, policymakers, and patients. A new paradigm of patient inclusion in all healthcare decisions has to be created, and the strong patient advocacy movement is going to be critical in ushering in a more egalitarian healthcare approach in Africa. Now, if we try and define political advocacy is a process by which an individual or group which aims to influence public policy and resource allocation decisions within political, economic, and social systems and institutions. And this can include many activities, including social media campaigns, public speaking, commission and publishing research. And lobbying for improved services is a key part of advocacy. Now, one of the things that happened with the HIV epidemic in South Africa many years back was there was a lack of official government recognition of the impending crises. And it was left to various advocacy groups to get together and to advocate on behalf of the disenfranchised HIV sufferers and effectively change the government's mind, which led to the provision of the drugs used to save people's lives. Patient advocates have carved themselves a niche and earned trust as peers and key partners in research, clinical and policy-making forums. Patient advocates are the link between the patients and the policy makers and the people that control the resources. There are lessons that we can learn from places where advocacy has been shown to drive change. So it's my pleasure today to introduce the various speakers who will talk about various aspects of advocacy from their own particular settings. So we have contributors from South Africa, Nigeria, and Zambia, plus all of you participants from all corners of the globe. So it's my great pleasure to introduce our first speaker this afternoon. And a huge thanks to Professor Alan Davidson, for stepping up at the 11th hour when one of our previous speakers was unable to make it. So Professor Alan Davidson works at the Red Cross Children's Hospital, part of Cape Town University, as a pediatric oncologist. And he's also the advocacy chair for an organization called CEOP, which is the International Society of Pediatric Oncology. So Alan, welcome. Thank you for taking time this Sunday afternoon to address us about advocacy for the pediatric population.
Thank you, Frank, for the kind introduction. It's an absolute pleasure to be here. On behalf of our organization, I'd like to thank both the organizers of Global Cancer Week. I knew that was going to trip me up, LGCW, and of course the leadership of AORTIC for inviting me to speak. And I'm going to talk to you guys. I mean, I hope I kind of fit into the breach of you know, Frank's very nice discussion. That's a fellow country person of mine, Chanel. The case for HIV, interestingly, is not a lot different to what we have to do in some ways. So I'm going to talk to you this afternoon, hopefully not too much length, about how we're making the case for childhood cancer. And it starts, because it's always about the money, it starts with an investment case. So we are interacting with a variety of agencies, the most important of which is always government. It's the fund holder, the guys with the money. And the value for money proposition with childhood cancer is that high-income countries have shown that an overall survival of 80% is possible. And the length and quality of that survival adds more value to the proposition, as does the relatively low cost of treatment, with good survivals even in the absence of high-cost biologics. Not that those don't help, but that's not the prerequisite when we talk about drug access. And there's good data emerging from our community about that relatively affordable price for treating kids. And we believe we can add value in other ways. First of all, we are absolutely committed to supporting universal health coverage. So there must be no competition between specialized services and basic critical services that enhance and improve under-5 mortality. And secondly, we believe, although this is more difficult to make an economic or numerical case, that the special place that kids with cancer occupy in the hearts of many of those parts of the multidisciplinary team mean that we believe that we raise the bar and improve services for other cancer sufferers and for other kids with chronic diseases. And lastly, of course, we want to collaborate with the whole community on the critical issue of drug access. And that's, we could talk for hours just about that question. So let's start local and look global at the size of this problem. No question that childhood cancer is less common than adult cancer, but it's still a significant burden. So looking at Johannesburg and Cape Town, we report about 90 new cases per million children between the ages of 0 and 15 every year. That's an age standardized ratio. And that rate compares, it's lower by about 1/3 than data from the US in SEER and Irish data, which suggests that the number for high-income countries is between 130 and 150 kids per million in that age bracket. Now, that may not be wrong, it may be different, but it's certainly less. And so when we talk about this type of number, I use 100 as a ballpark starting point. That's a minimum. If we look at our registry, our National Children's Cancer Registry, you can see that data, historical data, shows an age standardized rate of about 45. That's half. And there are differences by ethnicity and region. Those are not real. Those are reporting differences, I suspect. So you see, even within our country, it's a layered question. But if we look at our current situation in pediatrics, we're reporting about 1,000 cases a year. And if we assume for the entire country 100 per million, that would take us to about 1,700 cases, 150, the US figure, about 2,500. So there's a problem with ascertainment, and I'll come back to that in a minute. Now, so let's go global. Sub-Saharan Africa, 1.14 billion people. And assuming, and this is ballpark average, it's probably a little on the high side, but somewhere around 40% of those people are under 15. That's 456 million kids, 45,500 cases per year. And again, I make the point, it's a minimum. The assumptions work on slightly, or the modeling works on slightly higher rates. And if you listen to the guys at Stanford and Harvard and sick kids who are doing some modeling, they're suggesting it's perhaps closer to a third more than that. But it's certainly nothing like what's being reported. So we are under ascertaining, and I use that term just so that people understand the reason. It's a bundle term. It represents both underdiagnosis, which is a significant problem, and underreporting. So kids that are diagnosed and treated with varying degrees of success, but then not reported to registries. So clearly there are things we can do by building and maintaining registries, by building networks and massively educating particularly our community-based health services. It's not about the parents. The parents bring their kids. They show up. It's about getting into the system. So what about the context? Now, before 2000, more than 10 million children died before their 5th birthday. 90% of them in 42 countries, and mainly perinatal mortality and infectious disease. And health priorities were, and to a large degree, are still focused on these conditions. I mean, for very good reasons. And we must recognize that's a context in which we operate. But there's hope. And hope, again, it comes back to money, folks. UNAIDS, Gates, the big agencies threw billions at this problem. And you can see the result of a concerted effort to control malaria, HIV, and tuberculosis meant that the under 5 mortality has fallen by a third. And that 2013 figure published in Lancet is out of date now. It's lower. So it's encouraging because less kids are getting sick, but also because it means that we have the potential in the oncology sector to attract more resources for another problem that, if you watch the high-income country process, will emerge. So what about survival rather than ascertainment? Now, these are nice, elegant little curves just up to the year 2000, showing the effect of multidisciplinary treatment, primarily the chemotherapy with a splash of surgery and radiotherapy, more than a splash, to be fair, but still. And you can see that in most tumors, we are batting over 80% in high-income countries, with some notable exceptions. So we're struggling with myeloid leukemia and neuroblastoma, but the overall survival in a high-income country center for kids across the board is about 80%, including all types of bad biology and so on. Clearly, we're not in that ballpark, and I'll pick up on that a little bit later. But what's the survival gap? Now, on the one hand, it's obvious, right? It's about, do we have enough doctors? Do we have enough chemotherapy drugs? Do we have enough theater suites with surgeons? Do we have the radiotherapy machines? Yes, that's part of the problem. But if you look here, can I just check in, Frank? Can you see my arrow when I move it around?
Yes, I can.
Okay, fabulous. So start at the bottom, guys. If 80 to 100% of kids have access, let's say 100% of the kids, everyone gets in, and your center can get 75% survival, then that's the true survival for your context. If, on the other hand, even if, I should say, your center can, let's say, get 50% survival for kids, which is doable with pretty basic limited resources, certainly in the index cancers, that does not translate into 50% survival if you have a problem over here on the left with access. So if only 10% of the kids get to your center, then the true survival in your context is 10%. So we have to just be careful. And of course, this survival data was reported as part of the Global Initiative for Childhood Cancer The documentation is available easily online. These don't even take into account access. These are reports of survival of kids who got to the centers. And you can see the bluer you are, the more that kids survive, and the redder, the less. So those are the issues that we're facing. Well, it's not about grinding an organ and talking about our problems. It's about solving them. And solving them is a combination largely of collaboration and engagement. And I'm going to talk a lot in the other 10 minutes of my talk about advocacy and the sort of things we're taking on, but I'll make some comments about research and harmonization. And of course, everything, these are kind of like themes and streams. Everything is about WHO because it's a major player, and WHO has traction with government. It's about government, and then it's about big international agencies, such as in pediatrics, St. Jude Global, which has significant resources and is making a very valuable contribution. So our engagement as an international society is now across these streams with all of these players. But just briefly on harmonization, this is a short list, there are more, of agencies active in Africa. So SIOP is active. The French African Pediatric Oncology Group, GFAOP, has done amazing things in Francophone West Africa and the Maghreb. St. Jude has made enormous contributions in a variety of places. INCTR is embedded and has been for a long period of time, and Global Hope out of Houston has also started some cancer centers and made an enormous contribution. The difficulty is harmonization. The problem is a whole lot of very well-intentioned people all doing slightly different things. And part of our not just our advocacy, but part of our initiative as a global organization is to try and gently get everyone into the same space. Even NCCN, which is more renowned as an adult group, has been writing guidelines for peds and now is seeking to write guidelines for peds in Africa, which is lovely, but perhaps we need to all work together. So that's the one issue is the adult sector is the same. I realize that. So these are some of the many ways that we share the same space. And then, of course, the research paradigm. So I stole the slide, but with permission, of course, from Rakesh Jalali, who's an old friend of ours from the west coast of India, where he started a proton center, and he gives proton treatment for a hell of a lot less money than just about anyone outside of the high-income countries. Rakesh was speaking at SNO, Sub-Saharan Africa in Cape Town 2 years ago, and he pointed out this a big thing is that we struggle so much when we're trying to deliver care. We're just trying to keep up and keep people alive to do research. And the wonder here is his point to the participants, we had about 200 people in the meeting before COVID, was start a registry, ask a small question for each disease and collaborate. And it's a lovely message, and I think it is doable. And certainly one of the appetites we have as a global organization is to foster research that has a low and middle income country focus so that we can answer the kind of questions that are pertinent for the people in this room. Okay, so advocacy in specific, what are we doing? So our fundamental major relationship is with Childhood Cancer International. I'll make the point that our advocacy committee, this is the global committee, has three Africans amongst us. Corrado Akansela, besides myself, of course, Corrado Akansela in Nigeria, who's linked to the Dorcas Cancer Foundation and carries the flag for survivorship. And Dr. Glenamba is a PhD nurse in the Cameroon who holds the nursing portfolio. So we're well represented, and that represents an interest and an appetite by SIOP to solve what you can see, all that red that I showed you earlier, and I'm going to show you again, unfortunately. And we have 16 active member organizations for Childhood Cancer International across. These are just lovely logos that I thought I would share with you, but these are the active partners across the continent. Clearly a lot of work to do, 34 to go and counting. So what do? We have an annual sort of a rolling program. International Childhood Cancer Day is on the 15th of February. Then we have Survivor Week in June, where we hold a big webinar. And then in September, Gold September, those of you who follow the ribbons will know that gold is for peds, and Gold September sort of finishes off the year for us. So we've just come out of a Gold September campaign. Right now, we are on a 3-year campaign, which has its major focus on ICCD, the International Childhood Cancer Day, and this wonderful theme that was originated this year is of messages of hope using hands. So the hands are painted by the, in this case, kids, and you can see Kayulu from Zambia painted a hand and wrote a message, and the message goes on the tree of hope, the tree of life, which is on the right-hand side, and that's all on social media and published. And our 3-year program runs through our hands, focusing on the kids this year. Next year will be through your hands, focusing on all the various parts of the healthcare team, and then through their hands, focusing on families and caretakers. And it's of some size here. So it's set up with regular contact between CCI, WHO, and SARP. The data on the right is from this year, so 109 country champion organizations from 85 countries. In the end, we had more than 1,500 participants from 70 countries who wrote their messages and decorated the tree. We have toolkits, messages in 33 languages about how one participates, and that's all housed online. And now the latest thing is Benson Power in Hong Kong's developed a Google form so we can capture, the size of activity. I think that's another important thing, is measuring that outcome is critical. Next year, as I said, it's about healthcare professionals. We want them to paint hands to see if we can get them away from work for 5 minutes. And in terms of thematics, we want to emphasize universal health coverage, the value for money proposition, and the importance of essential medicine. So a working slogan, and this is unofficial, so we'll see how it pans out come February next year, is the right treatment at the right time with the right support. Okay, so that's the parent and survival. Well, it's a parent organization primarily, and that we are hoping to build a durable survivor organization globally at the same time. That's part of our brief. Next thing is the work that SARP is doing primarily, which is to move that cheese. This is the Global Initiative for Childhood Cancer, and we're working closely with WHO. The idea is that this is country level. So countries adopt a technical package which has been designed by the WHO, which helps to treat the 6 index cancers. And the idea is to move this cheese, to move this 30% survival in low and middle income countries to 60% by the year 2030. That's 9 years away, so that's a very ambitious goal. Look, we've enrolled one of the technical officers at WHO, Andre Elbawi, who's given enormous energy to the project. St. Jude have been fantastically helpful. And you can see that the DG is on board. He's not just on board, he's on record. So that's a good start. But we're starting at some basic levels in low and middle income countries. There are myths that I'm not going to read these out. I'm going to leave this up for a minute or so, just so you guys, these are the kind of things that we're trying to debunk as we move forward. And part of trying to build success for that technical package is precisely to unpick these locks. So the focus is on more princes, if I can use a rather sort of poetic terms, and on 6 index cancers that in high-income countries have very good survivals: ALL, Burkitt lymphoma, Hodgkin lymphoma, retinoblastoma, Wilms tumor, and low-grade gliomas. And in this regard, there is a package of adapted treatment regimens that are being designed. I mean, there's been a lot of work done over several decades on this, but now we're trying to package them in such a way that they're easy to use and you can access them online and roll out treatment for kids. In terms of our paradigm, you can be involved as a country at various levels because we accept that things can take time. With formal Ministry of Health engagement, you can roll out the actual technical package, and that's happening in Ghana and Zambia, which is very exciting. In terms of countries that are making early participation, that's happening in Senegal and Mali. And so these are hopefully countries that will come online over time. And Zimbabwe is also having a conversation in that regard. So that's very exciting. And that's practical. So the practical aspects of how we change the sort of data that I'm sharing with you. At the same time, we knew as a global organization that we needed to map out the current situation. So we have a global mapping program using a questionnaire survey type approach, which has gone out via our networks to all the healthcare providers. We started with Africa, where we perceived the most need. And you can see that, again, here, this is a snapshot as of 2019 or so. It will change over time, but it's a starting point. And you can see that we've developed a picture of what's going on in the continent, where there are full-time oncology doctors, for example, and where there are no full-time doctors. So access to chemotherapy, access to radiotherapy, and again, very simple rubric. If it's dark, there's more access. If it's light, there's less access. Who has specialized pediatric surgery, and then where there are trained pediatric oncologists. So the data is a lot more detailed than that, and then you'll see there's several publications now out in pediatric blood and cancer. Arrestingly, there are at least 7 countries where there are no services whatsoever. Now, of the 1.1 billion people, that's a small number, but it's still a significant number of folks that are not covered by services. So clearly we have collectively work to do. But to quote from my brothers and sisters in Malawi, in Chichewa, there's a saying, pangono pangono, which means little by little. And I think we have to recognize that that's part of the journey. That we need a measure of patience and a measure of urgency all at the same time. I have permission from Frank, I will tell you, to flag up a session at LGCW on Wednesday. So that is 18:30 GMT. There's a bespoke pediatric session on childhood cancer services in Africa, gaps, inequalities, and solutions, and I'd encourage you to attend. And lastly, please do join us if you have an interest, or if you have pediatric colleagues, please let them know about the South Africa Congress, which is in March next year in Kampala. And with that, I thank you for your kind attention. Thank you, Frank.
Thank you very much, Alan. It's very instructive for those of us that work in the adult world to know what's happening in the field of pediatric oncology. So it's not something that, as an adult urologist, would engage with. So thank you very much for bringing this up to date. I think we can take a couple of questions, bearing in mind there will be a panel at the end of the session where other questions can be put. So people can use the chat, or if anyone puts their hands up to and wishes to ask a question to Alan, then please feel free to do so. Any questions? No. Okay. Perhaps you'll save them up for the panel. So I think we'll thank you very much, Alan. We'll move on to our next speaker, who's a speaker from Nigeria. I can see there is a question in the chat. Perhaps Alan can respond to that. Our next speaker is from Nigeria. It gives me a great pleasure to introduce Runsi Chidebe, who's the Executive Director of Project Pink Blue. And his title is the Womanization of Cancer in Africa, a case of prostate cancer advocacy in Africa. So Runsi, thank you very much for being available today to talk to us from a Nigerian perspective. You're very welcome.
Thank you very much, Prof. Really appreciate the opportunity. Good afternoon, everyone. Thank you all so much for joining this afternoon for this very important session. My name is Ron C.W. Chidebe. I'm the Executive Director of Project Pink Blue. And my presentation today will focus on what I titled Womanization of Cancer in Africa, a case of prostate cancer advocacy. Well, I mean, I work with Project Pink Blue. We're involved in cancer awareness, advocacy. I will talk more about it in my presentation. So I will start this presentation, from looking at prostate cancer first. I mean, as we all know, prostate cancer is the most frequent cancer in men and the sixth leading cause of death in men. And in Africa, we've had like over 80,000 prostate cancer, cases and over 42,000 deaths in 2020. And in Africa, I mean, Alan already mentioned about the population of 1.3 billion people. And Africa has been described as, has really been described as, a continent of young people because of the, young population and also the birth rate. However, despite all this, you still see that 80% of all deaths occur among younger people who are, 60 years, below 60 years, compared to like in Europe and in Asia. So aging is actually an issue that really needs to be studied for us to get a better understanding of prostate cancer. Now, I sort of put this data together because it's important to understand how this disease affects different parts of Africa. In South Africa, we can see that 9 in 19 men are at risk of prostate cancer. And in Burundi, for a very small population, a country that has a very small population, over 450 men actually die from this disease. Same is applicable to Kenya, where it's actually the 5th leading cause of death. Algeria, the same thing. And in Nigeria is also very common in Nigeria as well. So the concern is that there have been a massive campaign, a massive pink campaign all over Africa. And this massive pink campaign all over Africa, which is replicated in terms of, which reflect breast cancer. And I have been asking the question, we invest a lot, we do a lot of talking, a lot of advocacy work around breast cancer, but very few work is seen around prostate cancer, which is the blue campaign. So several decades ago, when you mention, or several years ago, when you mention cancer, what usually comes in the mind of many Africans is that cancer is white people's disease. In my own estimation, I think we're already transiting now. People are beginning to be more aware in many communities, but we're transiting and moving into what I call womanization of cancer in Africa. What do I mean by this is that many Africa today assume that cancer is a woman's disease. This poorly taught, notion has a huge implication on prostate cancer and other cancer that affect male. Now, when you are in a conversation, including policymakers, I mean, I have been in a meeting with a senator, and he was shocked to actually know that men also have cancer. So this new notion or this new wave of womanization, of assuming that only women actually have cancer, has serious implications on controlling prostate cancer in Nigeria and controlling prostate cancer in Africa, and also as well advocacy for prostate cancer in Africa. Number one of the first implications is the lack of priority for prostate cancer. Number two, poor investment to prostate cancer intervention. I will talk about this into one of the interventions that we implemented in my organization, Project Pink Blue. And it took us several years to be able to get funding for this prostate cancer intervention. So you realize that even banks and corporate organizations would prefer to invest more in the PINK campaign, the breast cancer, the cervical cancer, but very little, for prostate cancer. Interestingly, in some of the companies too, even where the male are actually CEOs, you also be shocked why they don't see investment in prostate cancer as a great deal. Another implication is the perception of cancer control as a charity instead of a serious business. I've always made this case every single time that cancer control is a serious business and not to be seen as, charity, like you're giving something just to support them. But it's something we all need to understand, that we're trying to control this disease so that the generation after us and our own generation will be really safe from this. And it also is implicated in poor awareness and advocacy. I will talk a bit more about the difference between awareness and advocacy much later in this presentation. The limited number of prostate cancer-led NGOs and programs. Across Africa today, we have so many breast cancer and cervical cancer NGOs, but very little on prostate cancer. And then impediment to decentralized cancer control. In Nigeria, for example, we have seen a very big wave of many wives of governors leading breast cancer awareness and cervical cancer awareness, and very little or even zero of any of the governors of the different states doing anything in cancer control. This is also the perspective or from the notion of womanization of cancer or womanizing cancer. So for these governors, they feel like, cancer is a women thing, so their wives should be the ones that should be dealing with issues around, cancer. And for this reason, most of the women actually, most of the wives of the governors doing phenomenal work, doing huge work across Africa, like in Ondo, in Kebbi, in Lagos, in Niger, many parts of the country, they're doing phenomenal work. But unfortunately, very little is done in prostate cancer. So we asked ourselves a question: what can we do to mitigate the burden of prostate cancer in our community? And the answer to it is what we call the Men on Blue. So in 2017, we launched this campaign known as Men on Blue. So one of the reasons why we didn't use the word cancer for it is that we realized that it's so difficult for men to also really come forward for cancer screening or even associate with the word cancer. So we have to find different ways and different innovative ways to ensure that people are able to embrace this campaign. And we launched this campaign known as Men on Blue. And the goal of this campaign is to create awareness. As you can see here, we organized massive awareness work. This happened in Enugu. We had over 3,000 men came out on the street to create awareness, to dance in the local music known as Ogene in Enugu, and carrying these big banners, talking to press and all the rest. We also engage men, we also engage women and children, because we realized that if you engage women, they could bring their husband, and if you engage children, young people like youths, they could also bring their fathers. So that was one strategy that we used that really, really worked. And then we had another one in Lagos, and you can see, we had some women who are actually directly leading this campaign and this advocacy. And then we also engaged, made it very innovative, like, getting fun activities around it. You can see some people riding motorbike here. And we also added exercise to it as well. And we engaged the press, because in Nigeria, for instance, 15 Nigerian men die every single day from prostate cancer. Every single day. If you calculate the number of men that have already died of prostate cancer this year, there are more than the total number of people that have actually died of COVID-19. But we have seen massive response to COVID-19, and we keep asking ourselves questions: what has happened to cancer? What has happened to prostate cancer? So we also use the media to shift this policy, to speak about these policy changes that need to be done. And we also have awareness materials, like 10 things to know about cancer, prostate cancer and prostate cancer handbook as well. And we provided screening as well to men as well. And I know, of course, screening is very controversial, but it's something that we can talk about in this later part of this presentation. And the interesting thing is that this advocacy project that we did, while we were doing the awareness, doing the free screening and engaging the public, the media, and all the other activities around it, we built a research around this advocacy project so that to ensure that we're able to share knowledge and also, sort of share what we've learned and also ask people all over the world to replicate this. And this work was published on Lancet in 2019. And I'm just going to share a little bit about the research as well. Yeah, so the research method that we used was two methods. We used a qualitative and also quantitative. So we gave out a questionnaire, 20-item questionnaire. And how we did it was once any man comes up to any of our outreach, because we had outreach in about 7 states, in Niger, in Abuja, in Lagos, in Enugu, in Port Harcourt, across the country actually. And we screened about 1,661 men. And out of those 1,660, we had about volunteers. We had over 900 volunteers who actually responded to the questionnaire, and we analyzed this questionnaire as well. And then we did the screening test, the PSA screening test. And what we did was, after the screening, we delivered the result of the PSA test to all the men. We delivered it through text message and also called them to provide explanation of what this test means to them and what they need to do. For men who we found that needed to do DRA, we recommended them for the closest, we navigated them for the closest place they could do DRA, and also encouraged them to actually do that. And we followed up after some time. We followed up after after 2 months, we followed up after 3 months, and after 6 months, we followed up to ensure that they still receive, they do the DRE. And interestingly, just to share a bit of data of the diversity of the kind of people that came to this program. Interestingly, the ethnic group known as Igbo had to be highest here, and then married people were highest, and Christian were highest, and then also in terms of education. Then we asked a few questions like, how do you normally pay for your medical, healthcare service? And we realized that a greater percentage, over 70% of people who responded to this question actually pay out of pocket. This clearly reflects on that it will be so difficult to control prostate cancer, at least in a country like Nigeria, if people have to pay for, for their healthcare services. And I think this is also implicated across many sub-Saharan Africa. You can see where Nigeria is. You can see in terms of, healthcare expenditure, where you can see in Nigeria, you can see that of Egypt, you can see South Africa and Germany and other countries. So this is just a very serious issue that needs to really be considered. And then in terms of the screening, we also asked the question, have you ever checked for prostate cancer? Has your doctor ever told you about to have prostate cancer? And you can see what the responses were. They're all no, no, no. And, has anyone in your family told you that they have prostate cancer? A greater percentage of the participants actually responded no. And then, are you planning to continue? Interestingly, most of them actually said yes. Are you planning to get digital rectal examination every year? And most of them were like, no, So, and then we also asked these questions about try to understand the level of awareness, from these men. Prostate cancer is a small gland that helps men with sexual function and bladder. So we're asked if this question is correct or not, and these are the responses that we all got from this. And then in terms of attitude as well, expecting DRE to be very, to be a very quick and easy procedure. So we asked this question to also know about their knowledge and attitude around DRE and also attitude around PSA. We did a follow-up qualitative study, which was primarily interview, where we call on these men and then follow up with them, understand if they have done the DRE and if they are willing to also do this next year and going forward, especially for men whose relation or people related that maybe like their fathers or their uncles have had prostate cancer. We did a follow-up study with them as well before we published that data. So critically, one of the key things we discovered from this paper is that a greater percentage of our respondents actually have to pay for their health care, which is a serious issue considering that only 5% of Nigerians are covered by health insurance. And we also, I also thought that this is really implicated across different parts of Africa, considering that several years ago, African health ministers came together in Abuja and then accept that 15% of the budget of every African country will be put into healthcare. Unfortunately, just a few countries have been able to implement that. You can see over here, Nigeria is still battling between less than 4 to 5% of its healthcare, of its percentage of the total budget being devoted to healthcare. Ghana is just still on 6.5 in 2018. Malawi is on 12, doing a lot better than Nigeria. Rwanda also doing very well. Zambia is still also fair enough. Nigeria in its cancer control plan actually stated that it needs $308 million to reduce the burden of cancer. Well, as of today, we haven't seen much have been done in funding the cancer plan. And this is also applicable to many African countries. So it's really important to look at how, cancer plans are not just designed, but also cancer plans are also designed to be funded. Because any cancer plan without funding, then it's just like a poly, plan. So, some of the recommendations that I want to make. One is for many NGOs to really, first of all, understand the clarity. I've heard in many meetings and many conversations, I realized that there's a need for every one of us to really understand the difference between awareness and advocacy. It's usually mixed up at some point. Awareness is usually targeted on the general public. Awareness is those sort of situations whereby information, either multimedia or audiovisual, is sent out or is being prepared or designed and implemented to reach the general public, to target the general public, target the community, target people to really know and take action that are within their own capacity. Awareness can also come in a situation whereby you're educating people to help in advocacy. Now, awareness is totally different from advocacy, but people use it interchangeably. Advocacy, to me, in my own estimation, is where this information and education is sort of targeted, or message is targeted to bring about policy change, targeted at policymakers. So I think, in my own estimation, that while we are creating awareness across Africa, and I think many NGOs, many cancer-led NGOs focus more on awareness, which is good, but I think we're getting to that level where we need to be a bit more radical, where we need to be a bit more advocate, where we need to invest more in pushing changes. Many of the cancer plans across Africa look really beautiful, but implementation is really, really poor. What can we do? Awareness is good, but advocacy is better. Like for me personally, I really think that with awareness, my organization, for instance, Project Pink Blue, through this Men on Blue project, we're able to reach about over 10,000 people, with a massive funding from ACT Foundation. Just imagine with one single policy change, an advocate for one single policy change. Over 1 million people can even be reached in 6 months. So that is why I'm recommending that a lot of cancer NGOs across Africa should consider investing more in advocacy than they're already investing in awareness. Yeah, another recommendation is prostate cancer screenings, screening guideline for African country. PSA is highly controversial. If you look at the benefit and harm, but I think there is a need for many African countries to consider its own screening guideline, maybe looking out from the NCCN and other other screening guidelines across the world that can be adapted, that is supported with data, that is supported with evidence. For instance, that something is field tested or is data and evidence is used from the US or Europe doesn't mean it should be applicable here. We have seen prostate cancer onset, early age, coming up on early age in Black people, especially in Nigeria and other African countries. Government at all levels, both federal, state, and local government, need to implement cancer plans. What we have seen is cancer plans are developed at federal level and never domesticated in any local level. And I think that it's only through advocacy we can ensure that prostate cancer care gets to the people at the lowest level where they are. I think also there is a need for health insurance to be made mandatory. I've always asked myself, why is it that health insurance, vehicle insurance is mandatory in Nigeria, but health insurance is not mandatory? Like if I'm leaving my house today, I will ensure that I have my vehicle insurance documents. And if I'm leaving my house, I live in Abuja, before I drive like almost 1 kilometer to my office, I will meet VIO, I will meet road safety, I'll meet police. Sometimes you could even meet more. I'll definitely meet like 3 different organizations. They are all enforcing vehicles to ensure that vehicles have insurance. But we don't have any single person enforcing anyone to even have health insurance. This has a huge implication on prostate health. The next is also religious community should adopt prostate cancer awareness for its members. Companies should make prostate awareness an issue and a mandatory health activity as part of their health days and stuff like that. African Union, I think this is where we all need to play a role and also support AORTIC and work with our international bodies to see how we could have a declaration on prostate cancer at the AU heads of government. So I will invite you all to join Men on Blue. Just visit our website, www.projectpingblue.org, to join our Men on Blue campaign. And I look forward to your questions concerning what I've just presented. And thank you very, very much for listening.
Yes, thank you very much indeed, Runcie, for that very thought-provoking talk. There's a lot that I'm sure we can discuss in the panel about the roles and responsibilities of the governments and how we as individuals can lobby, can advocate for improved services. And I'm very much struck by this whole idea of health insurance. As you know, even when you raise awareness, even when making the diagnosis of prostate cancer, affording the treatments, it becomes a whole other issue. And I in the diaspora, and I'm sure many others have the same thing, where not a week goes by without a relative asking for remittances to pay for healthcare. So thank you very much, and thank you for the work you're doing in the area of prostate cancer, which is an area close to my heart. So are there any questions for Runcie? There will be an opportunity later during the panel discussion, but if there's any burning questions or comments, I can see there's some activity on the chat. I don't know if any of those people want to raise a question, or perhaps allow Runcie to respond on the chat. Any takers? Any hands going up?
Frank, I put my camera on. Just Runcie, that was fabulous. And it comes, may I, Frank, just for a second?
Yes, please do. Please do.
I want to be provocative. And it's a point I was making, and Runcie's made it too. It's about the money. I mean, we can go around the houses. It's about the money. And national health insurance is one paradigm. Personal health insurance is another paradigm. But money is politics. People make choices, and politicians make choices about what they spend our money on, our tax money on. And the one thing that we can do, and I'm pretty passionate about that, is go after civil society for votes. I mean, that's where I think that's the Achilles heel of the truculent politician is, you know, the difficulty is there's so many demands for those services, but there's so many other things that tax money is spent on that could be spent on health. So, yeah, anyway, that's just a thought.
Thank you. Aisha Mustafa, can we unmute her, please? Aisha?
Hello, I don't know if I'm heard. Good
Yes,
afternoon, everybody.
yeah, we can hear you.
Thank you so much to the first presenter and also to Ronsi for a very thought-provoking presentation. Yes, there were many take-homes from your presentation, especially the issue of healthcare financing. We know it's a very big challenge and every Nigerian is talking about this. And I just wanted to make a couple of comments and probably ask some questions to the second presenter. Yes, prostate cancer is actually of huge burden to the Black man. And I think the federal government of Nigeria have also realized this by making prostate cancer one of the 3 cancers that have been included in the currently ongoing Cancer Health Fund for treatment of indigent Nigerians with breast, cervical, and prostate cancer. So yes, I think the federal government is actually thinking about prostate cancer, and the issue of womanization of cancers. I don't know if I should just add my thoughts on that. I think probably the first ladies of Nigeria, as you rightly mentioned, are doing very great work on cancers. And in my own opinion, I don't think cancer is being womanized in quotes, because I was actually a bit surprised that people don't know that men develop cancer. And I think that is something that we should do a bit more research on to be able to have statistics about that. I know that the major problems are that people are not aware that cancer could occur in children, but I'm hearing for the first time that some people are not aware that cancer could occur in men. And the issue of the first ladies against cancer, probably, could it be that they're actually coming out to tackle screenable cancers, to tackle cancers that have been proven without any reasonable doubt that screening actually reduces the risk of dying from these cancers? Because in a resource-constrained setting, I don't know if diverting resources to screen for a cancer, prostate cancer specifically, in which screening has not been shown to actually reduce the number of deaths from. I don't know if anyone will advise a country struggling with resources to go into screening for prostate cancer when we know that screening for breast and cervical cancer are undoubtedly going to reduce deaths from these cancers. Now, other cancers that are actually screenable, I mean, even if you check on the CDC website, it categorically states screening for breast, cervical, colorectal, and even lung cancers could be shown to reduce deaths, and categorically stated ovarian, pancreatic, prostate, and other cancers have not been shown to reduce deaths from these cancers. So could it be that it's because the women cancers are actually screenable and deaths could be prevented? Could that be the reason why this government officials are actually tackling it more rather than actually womanizing breast cancer? I think this is a very important thing that we should be discussing. Thank you very much for the opportunity and interesting discussion.
Thank you, Aisha. Ronsi, do you want to respond to that? I think I will respond to that in the panel discussion about the efficacy of prostate cancer screening, because it is, I'm afraid to say, incorrect to show that prostate cancer screening does not save lives. There's a European randomized screening study, which is now something like 18 years out, that shows a 25% reduction in prostate cancer mortality. The arguments for screening is to do with the overdiagnosis and the overtreatment. It's not to do with the fact that it hasn't been shown to save lives. But anyway, we can discuss that more in the panel discussion.
Okay.
Ronsi, do you want to respond to that quickly? And then I'll go to Christine Wakesa, and then after that, we'll go to our next speaker.
No, I mean, it's up to you if you want me to respond now, maybe respond in the panel.
If you could respond in the panel, I'd be grateful.
Okay, that's fine.
Christine, can you ask your question? Okay, Christine, you're on.
Okay, thank you, Francis. And thank you all speakers so far. I should applaud Ramsey for that very beautiful presentation. Actually, I had started my chat or question with a chat. Why does prostate cancer take long to manifest? And most people are diagnosed at advanced stage. Ideally, they couldn't see any symptoms to prompt even seeking for medical care. And Francis, you actually put it correct that men may ignore symptoms due to lack of knowledge or fear. Actually, mine is just a comment and not ideally a question. As I said, my name is Christine. I come from Kenya. I work for the Moi Teaching and Referral Hospital. I am an epidemiologist and coupling also as a health administrator. In my daily duty, especially in epidemiology, I've been able actually to gather or to have access to actually what we compile as far as cancer is concerned. And as you put it, actually, there have been actually low like documentation on prostate cancer, especially in our region, the Western region. And I feel most men are either not coming out or these cancers are not being screened, or if they are screened, we are not documenting enough, especially like what we are best for our cancer registries in Kenya. We actually getting who comes to the hospital. And actually, which is a disparity from what is happening around us or in the community, because then until someone comes to the hospital is when you are documented. So majority or most of the actually cancers are left unpicked, and we are having a wrong actually data. We're having wrong data of this disparity, because then we have not even factored in some of the private hospitals around in the community. Because if someone hasn't come to the hospital, which is also limited because most of the hospitals, even the community, which are low level, are not even able to diagnose. So there's a lot that we can do, especially in the communities, to create an awareness, or rather the way Rancy said, advocacy, because then we have to make this accessible for treatment and care. And that is when we can document and have to actually support or help our population. Why do I say this? It's unfortunate. I lost my dad to stage 4 metastatic prostate cancer in the last 2 months. And actually, he has had it for the last 10 years. He was diagnosed like 10 years ago at stage 4. He has managed to pull through until maybe after 10 years is when we actually we actually picked it out, which was already stage 4. And so I feel there are most people who could have these cancers, but they're not diagnosed. Simply the symptoms are not out, or they fear somehow to come out and be supported. So then I've come up with a foundation just in commemoration, remembrance of my dad. The Wekesa Foundation, which I intend to launch. And actually, because around my village, there are several cases that when we come for screening, we've picked out. And I feel I'll reach out to the western part of Kenya to ensure that actually every year of commemoration, we will have a free medical camp that picks out, we screen women, we screen men, we actually create awareness and even advocate for access to treatment. And I feel I want to partner with even like-minded people who could actually send this, because I feel there's a problem in the Western Kenya region because of the prostate cancer. Unlike the women cancers, the cervical, the breast have really been actually gone round, or maybe the women are a bit flexible to come to the hospital. But I think there's a disconnect for men, because we hardly get them, or if we get them, we are not able to diagnose at those level 1, level 2 hospitals. Until maybe someone comes to a referral hospital in Eldoret or Nairobi, which actually would take so much and get it at advanced level, and when we could only just maybe help them palliative care and not maybe aggressively treat and maybe stop the progress of cancer. Thank you.
Christine, thank you very much for your comments, and I'm sorry to hear about the loss of your father from prostate cancer. The issue of men not presenting themselves, not coming forward, I think it is a worldwide phenomenon. We struggle with that. We struggle with that in the UK, and men die earlier than women, and a lot of that is due to less good health-seeking behavior. Let's put it that way. So I think we'll move on now in the interest of time to our next speaker. I'm delighted to ask Karen Nakawala, who's from Zambia, to talk to us about cervical cancer. So Karen is the founder and executive director of the Teal Sisters Foundation. And thank you very much for making time this afternoon to talk to us. So you're very welcome, Karen. Yes, welcome.
All right, thank you. I think it's technology trying to. Well, thank you so much. First of all, thank you so very much for the invitation, and it really is an honor. I am a cervical cancer survivor. I was diagnosed in 2019, and I did my treatment, I think, in like 2 months. And so after I finished my treatment, that is when I decided to start the Teal Sisters Foundation. And this is because in Zambia, I don't know about other countries, any diseases, any cancers below the belt, people don't want to talk about them for obvious reasons, you know. And so I thought, I would like to believe I'm a fairly exposed person. And for a fairly exposed person like myself, I knew very little about cervical cancer. And so if me in the position that I am in did not have as much information, I thought about my sister in the rural areas. I thought about my other sisters, you know, and that is why I decided to come up with the Teal Sisters Foundation, which was started on Facebook. And immediately we started it, within a month, we had over 100,000 women. And for me, that just meant that we needed to have these conversations, and it was time we had these conversations. And so that is how the Teal Sisters were born. So we're currently sitting at just about 150 plus or minus 1,000 women, not only from Zambia, but from across the world as well. So when I was invited by Frank to come and speak, I thought maybe I could just talk about the efforts, you know, to prevent and eliminate cervical cancer, because I am involved with the WHO's strategy to eliminate cervical cancer. And then I'm also sitting on the task force to eliminate cervical cancer in the Commonwealth. So I thought maybe I could speak a bit about that. I don't know if I'm able to share my screen, Frank. Hi, Frank, can you hear me?
Yes, I can hear you. Yes, I can hear you. I'd muted myself. You should be able to share your screen.
Okay.
Let's see. Let me see if Sky can make you a co-host to enable that.
Hi, Karen, you're already a co-host, Frank.
Okay. Share screen. Okay, so I can pull out. Sorry, I'm a bit of a technology failure.
That's no problem. It's all right. We'll get there.
Well, yesterday will be good. Okay, what am I not doing right? Are you able to see my screen?
We can't see your screen as yet. When you click, I think
I'm looking at it.
Yeah, often when you click onto share screen, there's various windows come up, and you have to select the correct window. And
okay, so I've got are you able to see it now?
Well, yes, we can.
You got it? Okay, cool.
We can.
You're getting somewhere. All right.
So if you just go to slideshow or start slideshow, then that'll be
slideshow. Okay.
Perfect.
Right. Okay, so I'm just going to give a bit of.
Not quite. Can you because we can see all your slides all at once. If you
okay.
If you go to slideshow at the top, that's it, and then select and then go from where it says from beginning, left where it says from beginning, from current slide, that's it. And then that should, yay.
You can see all of it.
Yeah, we can see your first slide. Yeah, all's fine.
Is that okay?
Yeah, that's good. That's good. Okay.
All right. Okay, so I'll get into it now. So I'll just give a bit of background, which you may know about, may know or may not know. So cervical cancer is the highest burden cancer in Zambia. And in 2018, Zambia had the third highest rate of cervical cancer in the world. And this was, we had, sorry, I can't see, no, okay, there we are. This is gonna be hard, Frank.
You're doing fine. You're doing fine.
Okay, so all right, we're good. Okay, so we had about 66.4 new cases per 100,000 women. That's age standardized to the world population. And the cervical cancer mortality is still very high, with an estimated 1,839 women dying from the disease in 2018 alone. And the high incidence is linked to the heavy burden of HIV, with a female adult prevalence at 13.8 in 2018. So when we talk about preventing and eliminating, how can we do this? I think firstly, we need to strengthen the WHO's 90-70-90 targets in order for us to, to be able to prevent, but also eliminate cervical cancer as a health problem. So I'll start with the HPV. There is a dire need for a paradigm shift as concerns the HPV vaccinations for young girls between the ages of 9 and 14. I'm not sure about other countries, but in Zambia, we're only able to vaccinate a cohort of 14-year-olds. Obviously, I think that is more financial, if you ask me. But it is sad when we hear stories of our friends in the West who are able to vaccinate not only the girls, but also the boys, and I think would also like to get to that point. So however, we need to actively engage the youth and also give them a voice and a place at the table as we design programs for them. Because I believe that there's no we can design a program for them without getting their input, without listening to them, because this is for them. And so it's very important that we engage the youth very, very actively. Also, the vaccine will have to be equitably distributed, especially to all African countries. I think I've been having a chat with Ranti in the background, and Nigeria does not have the vaccine. And like I said, in Zambia, we only have vaccine for 14-year-olds, but even then, that is not enough, So there's need to create massive sensitization about the vaccine in order to dispel all the myths and create an improvement on the uptake of the vaccine. Most parents believe that if their children are vaccinated, they're going to be barren, they will not have children, or they'll come up with all sorts of diseases. So we need to come up with messages that are going to help dispel these myths. We need also to have targeted and child-friendly messages, which should be designed and distributed in schools. Messages targeted at parents and guardians and communities as well should be developed, because there's no way we're going to win this fight if we do not include everybody in the fight. And so I think the solution will be for us to actually integrate the HPV into the school curriculum so that they're able to start learning about this from an early age, and they'll be able to grasp it and understand what it is about. Because I think as it is now, we just speak to the parents, and only very few parents know a lot about HPV, know anything at all about HPV. So I'd like to, I think, suggest that it is included in the curriculum. So they start learning from maybe grade 1, going on to grade 2. By the time they get to high school, they already know what HPV vaccine is about. And when it's time to take the HPV vaccine, they'll be well aware, about it. And I think we're going to see an uptick in the HPV vaccine. We also need to raise awareness on HPV screening and its importance. And this is HPV screening and testing. We need to create appropriate and tailor-made messages for target audiences. Now, I think CSOs, yes, we can go around and create all these messages, but we certainly overlook certain pockets of people in society, like women from the rural areas who cannot read, So you give them a pamphlet that is talking about HPV vaccine. They don't know what it is. And even if they are able to read, they're not able to understand what it is. So it's very important for us to tailor-make messages that will be able to cater for everybody. And I'm very passionate about including husbands and extended family, because this I speak from experience. Had my partner not known what cervical cancer was, he probably was going to run a mile the minute I was diagnosed with cervical cancer. So I think all messages that are related to cervical cancer should be inclusive of our partners, should be inclusive of our families, should be inclusive of our communities. And that way, I think we're going to have better caregivers as well if we have messages that include almost everybody in the community, instead of them just being targeted at the women. Because I believe that when a person is diagnosed with cancer, everyone around them is diagnosed. We heard about Christine and how she was affected, when the father was diagnosed with prostate cancer and later passed on. So all the messages that we put out there should be inclusive of everyone. There's also need to have peer-to-peer engagement. Ever since I finished my treatment, I've come to believe that my voice as a survivor is very, very important. And it's also very believable when I talk to the next woman and tell her, you know what, you need to go for screening, go for HPV screening and testing, go for cervical cancer screening. I think it's more believable because I have lived it. It's different if a medical person is going to just read out to them, something that they read in the medical books and something that they practice every day. It's more believable if it's coming from a story that has been lived. So peer-to-peer engagement is very important. I'd also like to suggest that we have HPV screening as a routine screening. When I walk into a center, when they take my blood pressure, in Zambia, I don't know, in other countries, we have HIV, which is mandatory. I think even HPV screening should be mandatory. I heard Rancy talk about, lament about prostate cancer. That should also be mandatory, You're not going to get any service if you don't want to do these tests. So I think that should be part of the routine screening when a person walks into the clinic. So the HPV test must be given for free, or at least made very, very affordable, especially for women in low and middle income countries who are at a higher risk of infection. They should also encourage self-sampling. With self-sampling, I think we're going to see an uptake in the screening because it is done in the comfort of your home. Like I said, anything that is below the belt, when you walk into a clinic and you tell the nurse, I want to do HPV screening, somebody who's watching or listening will think, oh no, what has she been up to? Has she been naughty? Has she been sleeping around? So if I am allowed to take the sample in the comfort of my home or in an environment that I'm comfortable in, I think we're going to have a lot of women, be able to take the HPV test and screening. And also, I don't know if we think about the differently abled. The differently abled, I think they have it. It's on the other hand, they have the stigma, the physical ability. They have the stigma of that, and then just the difficulty of going into a center and getting screened. I think that's just like double trouble. So we need facilities to also be friendly with people, especially women living with disabilities, because they find it harder to get screened physically and even mentally. Of course, both the test and the treatment should be aligned. So it should be a case of screen and treat, But however, if the results are not ready, if you ask me to come back next week on Wednesday, make sure that the results are there. Because we're going to lose a lot of women who are not going to go back to get their results. especially that there still is a lot of misunderstanding around the screening. There still is a lot of phobia around the screening, and most people will tell you, what I don't know is not going to kill me. So if it's possible to get the results there, and then that'll be good. But if I go back to the clinic, make sure you have the results for me ready, and then also if we're going to get more women to screen, it would be nice to go to targeted places like churches, universities, colleges, where you find a large pocket of women in one place. That way they won't be able to run away. Even if you have to take the results back to them later, you will still be able to find them because they're in this sort of confined environment, unlike just having the women walking into the clinic on their own. When it comes to cervical cancer screening, I think we need to encourage regular screening for women. Like I said, if we can make that mandatory also, that is going to be, I think it will be our saving grace. We need to continue raising and creating awareness about cervical cancer. And also targeted messages, like I said earlier, we need messages that are going to be heard by different types of people from all walks of life. I saw in Rancy's presentation where they were doing aerobics and there's a health talk happening. You've got the media. Such relaxed environments are really good because there's something about mob psychology. If my friend is doing it, I also want to do it, and if it's in a fun and relaxing environment, yet health conscious environment, I think it's going to draw a lot of people and push them to do what is right. Okay. And then women living with HIV, like I said at the beginning, women living with HIV are about 6 times more likely to develop cervical cancer. So more population-based programs need to be created. And in Zambia, most of the cervical cases are linked to HIV. And so it's very important that this pocket of women is looked at critically and made sure that we have programs that are targeting them so that we try to minimize the risk of them developing cervical cancer as much as possible. Also, health talks and symposiums, they do help in spreading awareness. In companies, which I have been doing a lot, companies have been inviting me to organize screening for their ladies. That has been happening. And now what we're doing is we're actually incorporating prostate cancer and breast cancer as well. Prostate cancer remains a huge problem even here in Zambia. Recently, we held a screening day for all the 3 cancers. We only had 12 men turn up, for screening. We were there the whole day from 6 to about 5 p.m. in the evening. Only about 12 men turned up for screening. And that is because I think there hasn't been a lot of awareness, there hasn't been a lot of education. And of course, the other point that both Ellen and Rancy brought up is that men are just scared to go to the health centers to get screened. So we hope to change that and just incorporate them in the programs that we make. And also, we need more highly efficacious screening, such as HPV molecular testing in all screening centers. But obviously, the costs remains a major barrier when it comes to that. So that is a picture of the ladies that we had when we held our event about 2 weeks ago. So we had some Zumba, we had some aerobics, and then after that, we went and had the screening, and we had over 300 ladies screening just in that morning. So routine screening will help in detecting pre-cancer cells, and these should be treated immediately so as to prevent them from developing into invasive form of cancer. Where possible, give the patient options of treatment based on your assessment. I know in the West, there are probably maybe 2 or 3 different types of treatments that are given for pre-cancer cells. And you probably find that in a rural setup here, you only have maybe LEAP, but where possible, it would be nice to give the patient an option to decide what kind of treatment they would like to have, but also based on your assessment as a healthcare provider. And obviously, we need to keep informing our patients to come back for their checkups after they've had the LEAP, the cryotherapy done. And also, another thing that is going to help us eliminate is addressing the barriers to treatment. For us to achieve the best outcomes, we need to address the many barriers to treatment, such as few treatment centers. In Zambia, we only have one hospital that caters for the whole country and also the region, because there's some countries around Zambia that do not have hospitals, cancer hospitals. So we need to increase the number of treatment centers. I know there is in the budget, I think plans to have 2 more centers opened, one in the south, one in the north, but that is just on paper at the moment. We have a shortage of human resource. We need more doctors, more nurses, and a lot of them, we've had a lot of brain drain in this department. So we need to have a lot more human resource. We need better access to radiotherapy treatment. For the last 1 year, there was a time, I think about 6 months, when our radiation machine completely broke down. So you can imagine what that does to a cancer patient. We didn't have the radiation machines, we didn't have chemotherapy either, you know. So now it has started, it was fixed and it's limping, but it's treating only about 25, 30 patients per day, when before we could have even 100 people screened. So this one machine that is working is catering for all the cancers, not just cervical cancer. Of course, cervical cancer being the highest burden and being the most cancer that is seen at the cancer hospital. So in our case, we need radiotherapy treatments available. We need the machines that we have there needs to be looked at, needs to be consistently maintained. And also the other thing that I have found is poor data collection and management. This needs to be improved. We have a lot of women that are coming from the rural areas. So imagine if I am coming from, say, 1,000 kilometers away from the treatment center, and then I go to it's time for me to go and get treatment. And then I get there and I'm told the machines are not working. I'm told there is no chemotherapy for you. Already, most of the families in the rural centers are living under $1 a day. And most women would rather sacrifice that $1 or the little that they have to feed their families than to go all the way and get treatment and actually find that there is no treatment at all for her to get. So you find most of them end up staying at home and just dying in silence, because they would rather feed their family than, you know, take care of their health. And so we need to have a lot of good patient navigation. That's what I was looking for, patient navigation. We need a lot of that. So that if the time for me to come for treatments comes, or is about a week away, somebody should be able to call me and say, you know what, Karen, do not come to a hospital because we do not have the machines. We do not have chemotherapy for you. We will let you know when you can come. But then again, what does that do to the cancer? Does it stop spreading because the systems at the hospital have stopped? No, it does not. So we need to improve everything all around. The continuum of care just needs to be improved all around if at all we're going to want to stop the cancers from spreading, and also for the mental well-being of the patients as well. And where possible, try to shorten the duration of treatment, okay? If my treatment is supposed to take 1 month, let it take 1 month. I don't see why it should take 2 months, you know? So we need a lot of things put in place in order for us to be able to arrest the situation and have better treatment outcomes. Where we don't have, like the situation I already explained, where we don't have, we need counseling for the patient, we need counseling for the caregivers, we need counseling for the community, for the families. They need to understand what is happening and how they can also be able to better care for their loved one. We need to provide enough information to the patients, the caregivers, their partners, their families, their communities at large, also to avoid stigma. There's a lot of stigma when it comes to cervical cancer. And a lot of women have died in silence because they don't want to talk about it. They're ashamed to tell people that they've got cervical cancer. They're ashamed to tell their parents, their partners, that they have cervical cancer, because everybody will start pointing fingers at them. Like I said, you know, it's a sexually transmitted disease. So yeah, you know what happens when somebody has an STI. So for us to eliminate and prevent. There'll be need for improved and enhanced cooperation and coordination amongst countries. You know, when I listened to Rancy speaking and I listened to Alan speaking earlier, I think it just strengthens the resolve that synergies is what is going to help us, you know, out of the doldrums. We need improved health delivery systems. We need equitable distribution of vaccines, especially here in Africa. I still don't understand why in Africa, where we have the highest burden of disease, we still have issues with the vaccine. But in the West, where they have the least burden of disease, they have enough even to vaccinate the boys. For me, this is one picture that just doesn't seem to leave my head. So we need equitable distribution of vaccines. The HPV vaccine should be accessed anytime by the target audience. Improved, consistent, and timely delivery of messages to target audiences. Increased awareness on HPV screening and testing. Improved delivery of cervical cancer treatment for better outcomes. We need to address barriers to treatment. We need to actively engage cervical cancer survivors and youth in the programs, like I said earlier. And also low and medium income countries need to be supported in providing better quality services to their patients, because as long as we have this burden in Africa, even the West will still be affected by it. So we need to be helped in order for us to get to where everybody else is. And I know it's something that can be done. And finally, I believe that it is every girl and woman's right to live a cervical cancer-free life, and every girl's right to have a cervical cancer-free future. Don't let another woman be a statistic, because together we can. Thank you again for your attention. Thank you, Frank. Apologies for stuttering at first with the technology, but thank you so much for the opportunity.
That's no problem at all. Thank you very much indeed, Karen, for enlightening us as to what's happening on the ground in Zambia, and some very important messages for us, such as the role of schools in educating the youth, which eventually I would imagine would translate through to better health-seeking behaviours, both for the boys and the girls. And also the importance of peer-to-peer messaging. You know, as you say, people believe and can relate to someone who's been through that particular experience. So those are very important messages. I'd like to invite anyone to ask a question before we move into the last 15 minutes, which would be the panel. So is anyone anywhere in the world who wants to ask Karen a question? I know there has been activity in the chat, and thank you for those who are putting links to videos or links to publications. So anyone raising their hand? I can't see any hands raised. Oh, Alan. Yes, can we unmute Alan to
I think I'm okay. I got co-hosted for my sins.
I think
Karen, that was fantastic. I think I want to steal a leaf out of the book. There's a Caribbean leader, a woman, head of state, and I'm profoundly embarrassed that I cannot find the reference at short notice. I've been trying to Google it furiously. She went to the UN and she gave the Northern Hemisphere. I think we need to be clear. We're talking about the North, not the West. The West is not the issue. It's the North. She gave the North what for? And she said, look here,
Yes, the North.
We need COVID vaccine, not you people. We need it. Now, you see, the cervical carcinoma story is exactly the same. And it's an intersection for me because, I mean, young people, I'm not sure if they belong to you or belong to me in an advocacy sense. They will get their CA cervix when they are beyond my care, but they are at risk for it when they are in my care. And I mean, it's a very strong message we need to send that just like the COVID vaccine, we need that vaccine. It's absolutely critical. And we need to make a noise. And the message we need to send through our leadership, through the OAU and others, is you guys need to give it to us. I mean, not from a benign perspective, but from a disease burden perspective, because we're all connected. So thank you.
Thank you very much. So if I could invite the panelists to be unmuted and to be available to take questions. So if I can invite Alan and Runcie and Karen to be unmuted, and this is the opportunity for participants to raise any questions or issues or commentary, and I'm sure one of our panel will be able to respond. So we have approximately 15 minutes for this session.
Okay.
If we need to round up, or indeed, if there's any comments that the panelists may want to add, having heard the other speakers, and again, this is the opportunity.
Prof, do you want me to go in?
Yes.
Want me to start? Okay. Okay.
So everyone, just before you start, anyone can unmute themselves should they wish to talk. Okay, Runcie.
Okay, thank you very much. I think I just wanted to, first of all, also just make a little, comment to Karen's presentation. Karen, we've been following you. You inspire a lot of women in Nigeria. So thank you so much for the phenomenal work that you're doing with the TEL Sisters. Yeah, I really, really appreciate you. Yeah, I just wanted to say that I think the COVID-19 and also cervical cancer enabled not having access to these vaccines have clearly shown the global inequity, right? And has also shown that global leaders are actually interested in things that affect them more than things that affect, some specific community. I will share this with you. Lassa fever has been killing so many health workers in many West African regions. Lassa fever has been killing many people since 1950, right? But there haven't been any vaccine for Lassa fever till date. But COVID-19 came in 2019. Right now we have a vaccine for it. So I think it's up to us in Africa to start thinking on how we all will have to wake up. Our volume is a very serious issue, and science capacity is a serious issue. So it's up to all of us to advocate and hold our leaders accountable to make that difference that we want. If we continue to look up to the world, global leaders, in terms of other countries, believe me, even till next generation to come, I'm not sure we'll still be battling with these same hurdles facing our healthcare challenges. Thank you. Let me just respond to the issues that Aisha raised, or comment or question. So I want to state emphatically that Aisha, that the inclusion of womanization of cancer, as I use it, in Nigeria and Africa, is not an attack on breast cancer or on cervical cancer or on anything. Don't say it that way. It is a call to action, to a new wave of notion happening around our community, happening around us. I'm not saying that we should rob Peter to pay Paul. That's not the idea, right? My concept of womanization of cancer is a clear call for NGOs to governments to incorporate cancer, prostate cancer, and really other form of cancer. Like, Alan talked about childhood cancer. Anytime I hear of childhood cancer, I personally also feel guilty because Project Pink Blue is not doing enough in childhood cancer, right? So, having worked in cancer control for several years and having worked with first ladies of Nigeria, I can attest that they're doing phenomenal work and still doing some great work, right? But for instance, in Kebbi State, the first lady of Kebbi, who is the founder of Medicaid, Dr. Zainab Shinkafi Bagudu, she's been working very hard. They just launched the Kebbi State Strategic Plan for Cancer Control, right? She's doing a phenomenal work with her sisters in Ondo, Niger, Cross River, Oyo, Kwara, and Enugu, right? Yeah, but the core message of my presentation is that we need to educate men more. They can play a more vital role than what we are seeing today. Imagine if the governors across the country are pushing the same way the wives of the governors are pushing. We will have more policy-driven changes in cancer control compared to what we're having today, right? We'll also have more sustainable interventions if we intentionally begin to educate them more so that they can understand this. And I'm telling you, based on my experience working as an advocate for several years, me and my team, led in 2016 the bill to establish the National Institute for Cancer Research and Treatment. That bill was signed by President Muhammadu Buhari in December 2017. Till date, the bill hasn't been implemented. And is a bill that if we have an institute, right now, what we have in the Ministry of Health is just a cancer desk that has about less than 20 staff, managing a disease that is impacting 100,000 Nigerians every single year and killing over 72,000. These 20 people can't manage it. We need an institute. So this is a call to action that there is a lot more that we can do by involving everyone and ensuring that everyone becomes an advocate. I think I will stop here.
Thank you very much, Runsi. Korede, can you unmute yourself and ask your question or make your comment?
Thank you so much. Thank you so much, Francis. Hello, Runsi. Hello, Helen. Karen, thank you so much for that wonderful presentation. And I was about commenting on Runsi, and thank God he quickly just explain himself, because I actually want to hold him with regards to childhood cancer. My name is Korede. I work in the childhood cancer space in Nigeria. And I actually want to hold his leg and say, okay, what are you doing with childhood cancer? And thank God he felt gift, and I love this. And I hope we need to all do something, as much as, like I've been saying in every forum, as much as we are talking about cervical. It's so painful when I saw the funding for cancer and then childhood cancer was not there. It's really an I feel very pained about it, that a little portion at least should have gone. That shows someone is not, is either someone is not listening, or it's not being pushed yet, or the stakeholders in childhood cancer in Nigeria, we are few. But I mean, forums like these and with commitment of everyone, I believe we are going to, childhood cancer is going to come up, because like you're saying, it's a good investment, because these children can survive with this early peak. So thank you, Runsi, for mentioning it, and I hope we will take actions for these kids so that they can survive, because most of them want to become a doctor to save other children. When you listen to them and see them speak, they too want to do something to the society. And so I think I would stop it. Thank you very much. Thank you.
Can I jump in, Frank?
Of course, Alan.
Coretta, thank you. And just to say that, guys, I think the trick is, I made this point earlier, because if you look at the burdens of disease, prostate, because we're talking about breast, prostate, CA cervix, colon. That's all, and then perhaps lung cancer. I mean, those are the massive burdens of disease. And in essence, we could all end up in competition. And the one thing we must not do is be in competition. We have to collaborate as we go. So the childhood aspect, see, there's a nice little niche there, because we have smaller numbers, we're affordable, and we can make, heads of state cry. So we need to work together on these things. And I mean, certainly there's an intersection, because even from a pediatric point of view, a 55-year-old gentleman, and I'm sharing my age embarrassingly, is somebody's grandfather.
Very true. Very true. Are there anyone else wants to pass comment or raise a question before I do the closing remarks, Ransi?
Yes, thank you very much, Prof. So, I mean, I got a message from Messi Ofuya. Messi is asking, do you have any suggestion on how non-profit initiative in diaspora can effectively engage in advocacy in Nigeria, for example? Okay, yeah. So I would say there are different ways non-profit that are based in diaspora can really support. For instance, I think what Professor Francis and his colleagues are doing are already a huge sort of support, getting us involved in meeting together, bringing us together, sharing ideas across Africa, like learning from colleagues from Zambia and all the rest. I think it's phenomenal, it's great, which I think other nonprofits who are in diaspora could also do the same. We could start doing it in different disease areas, right, to strengthen our capacity and connect we on ground in Africa to different resources. I will share something with you. If you Google cancer survivorship in Nigeria or in Africa, you will be shocked of what you will see. All you will see is actually people who are all dying. Or Google cancer in Europe, all you will see is graphs and all sort of sketches. You can go ahead and Google it right now as I'm talking. So this is a reality. You see sketches and graph, data, evidence, and all the rest. But Google cancer survivorship in Africa, you'll be shocked. All you see are pictures of people who are dying. So I think we need data. We need to publish. We need research. We need lots of support, right? And when I talk about research, I'm not talking about helicopter research. I'm talking about, like what the e-cancer is doing, that when you want to publish a data from low and medium income country, you have to incorporate them who are on ground as well to be part of the authors, right? So what am I trying to say is, number one, as I said, you need to provide some platform, connect us to resources, support us in terms of research. If you have funding, you can also support. For instance, for example, a clear example in Nigeria at the moment is that the President Muhammadu Buhari, have signed the bill to establish a National Institute for Cancer Research and Treatment. That bill was sponsored by Senator Mao Ohuabunwa, right? But this bill, as I'm talking to you, was passed by National Assembly in 2016, signed by the President. This bill hasn't been gazetted for it to become a proper institute that people can really respond to. Even though the federal government have launched the Cancer Health Fund, it's being managed by the Federal Ministry of Health that has a lot of competing priorities with malaria, with other infectious diseases and all the rest of them. So we need an institute, the same way we have National Cancer Institute in the US, and in the UK, you have all sort of different agencies dealing with cancer. We need that in Nigeria. If we don't have that, then we can't really make progress. So Messi, if you can support advocacy organizations in pushing these things, organizing press conferences, engaging with policymakers, hosting a meeting with other diaspora to see how you can support. There are different ways, please. I don't mind sending my email and we can talk after this.
Thank you. Thank you very much, Ransi. One of the benefits of such a forum is to bring people together, people who have got similar challenges in their own domains, learning from each other as to like how to engage men better, for example, is one very, very good example. And also the other benefit of such a gathering is that we get inspired by what others are doing, and it enables us gives us the energy to do even more. At times we can get the feeling that we're working alone and no one else is interested. There are lots of people interested, and such a forum as this gives us that opportunity to share what's going on. So I'd like to thank London Global Cancer Week for giving AORTIC this opportunity to present what's happening on the continent, and in particular, giving us the opportunity to talk about advocacy for improved cancer care and improved cancer services. I'd like to thank the AORTIC Secretariat for the logistical support without which I think we would have been in serious trouble today. So thank you, Sky and Bilmira in particular, and the other AORTIC Secretariat who have supported them. And of course, you know, it's no good trying to organize a meeting if no one wants to talk at it. So a huge thanks to Alan Davidson, particularly for stepping in at the 11th hour, and to Ronsi Chidabe, that I've had the opportunity to share various sessions in different meetings this week, and Karen Nakawala for sharing her personal experiences and taking the initiative to try and improve cervical cancer care in Zambia. And of course, no meeting is complete without the participants. So thank you for giving up your Sunday afternoon for the last couple of hours to help move the dial. And there are other London Global Cancer Week sessions. I think Alan made mention of the pediatric oncology session, which is, I believe, on the 17th. I think it's the case. So I'd encourage you all to get onto the London Global Cancer Week website and avail yourselves of the other educational and learning and advocacy opportunities. So it's for me to wish you all well and stay safe.